Welcome to Healthline 3. I'm Jade Balexa. Thank you for joining us. October is Sudden Infant Death Awareness Month. About 3,400 babies in the United States die suddenly and unexpectedly each year. And we have advice today that could save your baby's life. Joining me now is Dr. G.E. Ghali, who is with the Willis Knighton Oral and Maxillofacial Surgery Institute. And Dr. Ghali, thank you so much for being here today.
It's my pleasure. Thank you, Jay.
Absolutely. So remember, you can call us at 318-219-4569 with your questions. So let's get started here. Tell us, Dr. Ghali, what is sudden infant death syndrome?
Well, it's a good question. I mean, sudden infant death syndrome, Jade, is a condition that I wish was less common, but as you said, over 6,000 infants died prior to the institution of the Back to Sleep program in the early 90s in the United States. And it's basically a situation where a child between the age of 1 month and 12 months dies and they can't find any other cause for why they passed away. You've heard of things like crib death and things like that, and that's what sudden infant death syndrome is. No one really knows the exact cause of it. There's been some recent data and studies that have come out of Boston Children's Hospital as well as out of San Diego in the neurology literature that have shown that some of these children on autopsy have had very low levels or abnormalities in the serotonin levels in their brain. And as you know, serotonin is important for a multitude of functions within the body, not the least of which is sleep and the regulation of breathing and things like that. So serotonin is a chemical in the brain, and that chemical it has some type of imbalance or receptor issue in the brain. That's believed to be sort of the current thinking of what the cause of SIDS is. But again, no one knows for sure completely.
Mm-hmm. Tell us, what are some risk factors that can cause SIDS?
Yeah, well, sudden infant death syndrome is associated with several risk factors. One of the most common risk factors that it's associated with is having a child that is sleeping in the bed with the parent. That's sort of a big no-no. And a child sleeping on their belly or on their tummy. One of the things about sleeping on your tummy and why parents like kids to sleep on their tummies is they get a deeper sleep. They're in a deeper sleep when you sleep on your belly. That seems to be one of the issues with sudden infant death syndrome. So recommendations were made by the American Academy of Pediatrics as well as the federal government, the NIH, to recommend since the early 90s for kids to sleep on their back. They initially called it the Back to Sleep program or campaign, and now they call it the Safe Sleep campaign, safe to sleep type of campaign. So sleeping on your tummy is probably the largest risk factor. Sleeping on a soft bed, sleeping with items in the crib, like a lot of pillows or toys or a lot of soft bedding. You really don't want that. You want a fairly firm type of mattress with little to no bedding, maybe a sleep sack or something like that for the child. Recommended that they sleep with a pacifier, actually, at least for the first 6 months. This is more of an issue. Sudden infant death syndrome is more of an issue in the 1 month to 6 month time frame. After about 6 months, when the child is able to flip around on their own and not get their face sort of stuck in the bedding or on the mattress, it becomes less of an issue.
Mm-hmm. What are some other ways for parents to reduce the risk?
Right. For parents to reduce the risk is to keep the child away from smoke at all. From a maternal standpoint, what parents can do is get good prenatal care, seeing their pediatricians, seeing their obstetrician to get good prenatal care, making sure that as part of that prenatal care, counseling for the mom not to smoke. Then once the child is born, to make sure that the child is not around us, is in a smoke-free environment. You can't keep everybody from stopping to smoke, but certainly they don't have to smoke within the house itself. Then from a sleep standpoint, it's important to, during that first year, I advocate that parents sleep in the same room as the child.
But not in the same bed.
Exactly, Jade, not in the
Yes.
same bed. So there's a huge difference between sleeping in the same room or having the crib where you can hear something or you can monitor that child. But you don't want to sleep with them. You don't want to sleep with them on a couch. You don't want to sleep with them in a bed. It's just not designed for that. So those are some of the major things. There tends to be sudden infant death syndrome for some reason or another. It tends to be more common in boys than in girls. It tends to be more common in certain minority groups, in the African American population, in the Native American population, in the Native Alaskan population as well. Nobody really understands why, but in those populations it tends to be more common. It also tends to be more common this time of the year toward the winter months. And there may be some association with upper respiratory infections, with viruses that kids get, and their increased difficulty to arouse themselves from a deep sleep, or if they get stuck in the bedding, to be able to pull themselves away from that.
Oh, so suffocation maybe?
Suffocation and things like that, right.
Okay. All right. So, and so that's why, maybe we celebrate, or not celebrate, but honor SIDS during October.
Right, and so like you mentioned, October is SIDS Awareness Month, and one of the things that we see with the Back to Sleep campaign, or the Safe to Sleep campaign, and sleeping on the back. Originally, they recommended sleeping on the back or on the side. The side was removed, and now there's no sleeping other than on your back. And that's most important during the first 6 months. When the kid's able to flip themselves back and forth, all bets are off at that point.
And so tell us, what is plagiocephaly and how is it related to SIDS?
Well, that's a good question. That's sort of my area of expertise.
Yeah, your specialty.
My area is not necessarily SIDS, but one of the things that we see with SIDS, when they're sleeping on their back, or in an attempt to prevent SIDS, I should say, with sleeping on your back, depending on how hard the mattress is and how soft the baby's head is, oftentimes the baby will favor one side to the other. Now, there is a condition called torticollis, which is a condition where there's a shortening or stiffness of one of the muscles in the neck, this muscle right here called the sternocleidomastoid muscle. And if that muscle is stiff, then the head becomes deformed because the muscles are pulling on the head and the head is tilted. That requires physical therapy and sometimes surgical intervention. But what we're talking about is a situation where the neck is normal, and in an attempt to avoid SIDS, which is important to avoid it, to prevent it, they're lying strictly on their back when they sleep, and their head shape becomes twisted. It becomes deformed because the baby's skull is very soft and real malleable, almost like Play-Doh, I would say. And because of that, the gravity pushes on the skull and it flattens their head. It'll flatten their head in the front, it'll flatten their head in the back, and it will deform their ears as well. And so how this relates to SIDS is the prevention of SIDS with them lying on their back. We see a lot of kids that have deformed shaped heads as a result of that. And I think that's sort of one of the risks of exclusively lying on your back as a baby. But I think the benefit of that outweighs the risk. The benefit is avoiding sudden infant death syndrome. So if we have to deal with a little bit of a misshapen head, that's not that big of a deal. It's not a surgical problem, and we can talk about what we do for that.
Yeah, so what age does the head flattening develop?
Well, you know, some kids are born with a flattened head. You know, it's not so common with cesarean sections, but with vaginal deliveries that may be very difficult, a very large head, a very small opening. Sometimes you get some head molding and misshapen heads just going through the birth canal. But most of the ones that we're talking about and most of the ones that we see are misshapen heads as a result of laying flat in the crib to avoid sudden infant death syndrome. And most of these flattened heads start around 2 months of age and somewhere between 2 and 8 months of age.
Okay.
Is the most common age categories that we see them. And when we see them, we will recommend that they have some tummy time. And please don't be confused. Tummy time doesn't mean they're going to sleep on their tummy. They're still going to sleep on their backs. But tummy time is a way for the mom and the dad or the grandparents to monitor the baby while they're playing on the floor or on a blanket on their belly. And then the kids will lift their heads up, and that really increases the strength in their neck and in their head, their ability to kind of manipulate their head, and it helps shape their head. But after a couple of months of this conservative therapy, if that doesn't work, then oftentimes we'll recommend that we put them in a helmet.
Okay. So yeah, let's talk about the helmet here. Can you show us how this works?
Sure. So we're very fortunate here in Shreveport-Bossier. We kind of teamed up some years ago with Snell's here locally and local regional company here, and they help manufacture these helmets. And back in the olden days, I'm going to take this helmet off.
Yeah.
And you know, Jade, this helmet's interesting because you asked me if the kids like to wear it or not.
Yeah,
like
I wanted
wear
to
it.
know before
And
the show started.
Actually, in the beginning, they hate it.
Yeah.
Then shortly, I'd say within the first month, they get really used to it. There's an initial break-in period. You wear this helmet 7 days a week, 23 hours a day.
Okay, so you wear it when you're sleeping.
You wear it when you're sleeping.
Wear it
Right.
when they're sleeping,
So-
and during the day.
And during the
when
day.
they're awake.
And so that way the parents don't have to worry about if they're sleeping on their back, that they're going to continue to deform their skull. So there are certain areas that are incorporated within this helmet to provide, depending on what type of head shape that they have, there's certain areas where there's contact to prevent further growth in that area, and there's areas that have openings in them or less contact to allow the head to grow into that more normal shape. So the way this works is that patients are referred, and actually at Willis Knighton South we have we have 3 clinics a month that are devoted to these children that have what we call positional plagiocephaly. And again, that's sort of a byproduct of lying on your back. But again, I'm not discouraging lying on your back. I'm encouraging lying on your back to reduce the incidence of sudden infant death syndrome. As a matter of fact, since kiddos started lying on their back, we've cut by 50% the incidence of infant mortality due to SIDS. It's gone from 6,000 or so a year in 1992 down to less than 2,000, probably a third of what it was before. So back in the olden days, we'd have to take a mold of their skull, just like when you would go to the dentist and they'd take a mold of your teeth. Mm-hmm. Nowadays, we use laser technology with no radiation involved to do a scan of the child's head, and then Snell's is able to then fabricate within 2 weeks a helmet. The helmet is worn for anywhere from as little as 2 months to up to 4 months. And usually just one helmet is required. And you may have some examples. I think we submitted some examples of
the before and after.
Right, sort of before and after. And you can see on the left of the screen the before. This is what I would consider moderate to severe, more like moderate left posterior positional plagiocephaly, and it's hard to tell, but the ears are displaced. One ear is sort of in front of the other ear, and so all that is corrected after about 3 to 4 months. No surgery, just purely done with the helmet. You can kind of see what it looks like there. And I'm not sure if you have another slide or not, but that kind of gives you a pretty good idea of the type of thing, and understand. Okay.
Oh, that is precious.
So
is that the same child?
No, this is a different child, and you can kind of see with her mom, Megan, and basically that's a child that's wearing this type of helmet, and they like to decorate the helmets.
Yes.
The helmet I have in my hand is sort of one decorated with LSU. For me, it'd be an A&M helmet, not necessarily an LSU helmet. But anyway, we got to go with what we got here.
Right.
Diane has let me borrow this helmet here, and so they get very accustomed to this. And so the whole purpose of this is it's non-invasive, and the parents don't have to worry about them sleeping a certain way. They can sleep any way that they want to sleep, and their head will not get further deformed. And so we follow up the patients on a routine basis. We get another scan of their head to see what type of improvement has been done. And we found that this technology has really improved the overall shapes of these children's heads.
Yeah, it's amazing what the human body can do. It just works itself out with the helmet on.
For sure. For sure.
So, is there cases where a baby has to have some kind of surgery to?
Well, there is, not so much for positional plagiocephaly, because that is more of just molding and shaping the head with the helmet. But there is a condition called craniosynostosis, where the sutures in the skull sutures, so we'll just use this as an example. There may be sutures where two bones come together in the skull. It's called a suture. And if those sutures fuse early, it can restrict the growth of the brain. That restriction of the growth of the brain can cause issues with the brain, obviously, issues with vision and issues with cognitive functions of the brain. So in those situations, that's diagnosed clinically and through x-rays, and that's a surgical problem. In those cases, we remove the suture that's fused and allow the brain to expand. That's not the issue with the head that gets misshapen as a result of sleeping on your back. That's a totally different issue. Now, you may have both. You may have a combination of this and a prematurely fused suture, but most of the time it's one or the other. And most of the time it's this, and most of the time it's treated conservatively with one of these helmets.
Okay. And we have a caller, Valerie. Valerie, what is your question?
Well, I was curious to know if it will delay any of, like their walking. Will it delay their walking or crawling or anything that will it, like I said, delay any of those things?
Would this condition delay any walking or crawling or anything like that?
So, Valerie, that's a good question. So, the deformational plagiocephaly or positional plagiocephaly, what we're talking about, sleeping on your back and your head gets misshapen, that won't have any effect on walking or talking or meeting what pediatricians like to call meeting milestones. On the other hand, if you have the other condition that Jade asked me about, the craniosynostosis, that certainly can cause issues when the sutures are fused and the brain can't grow. The brain can grow normally with the positional plagiocephaly. It's this one that it becomes more of an issue with, and that's why it requires a combined approach with a craniofacial surgeon and a neurosurgeon. But this is fortunately not a problem. And so when we talk about positional plagiocephaly, that's not something that's going to cause cognitive issues, brain issues, issues with walking or meeting milestones.
All right.
Okay, good. Yeah, because what I was thinking that the helmet maybe throwing them off a little bit, but I guess they adapt to it, like you said, after the first month, and so it doesn't hurt any of those skills.
Yeah, she was worried the helmet might throw them off in the first month, but um, she was concerned about that.
Throw them. Oh, you mean this causing ambulation?
Yeah.
No. As a matter of fact, as I mentioned to Jade here, after the first couple of weeks, the kids get so accustomed to the helmets that they almost prefer them to be on than to be off. And I will tell you that 2-3 months ago, when it was 105, 110 degrees, that wasn't good. I mean, the kids didn't like the helmet so much because it was so hot underneath the helmet, as you can imagine. This time of the year, thank the Lord, the temperature is getting a lot cooler. It ain't going to be a problem, and they adapt very well to these helmets. And matter of fact, like I said, they love wearing them.
Okay. Valerie,
Okay,
anything
thank
else?
you.
Okay.
That's it. Thank you.
All right, thank you. All right, yeah, those are some good questions. Yeah, I can imagine the heat would make it a little uncomfortable.
It is, and that's one of the other things. One of the known risk factors for sudden infant death syndrome, separate than what we're talking about here, is getting a baby that's overheated. You want to keep the baby kind of cool in the crib, maybe a little fan or something like that going. Them getting overheated becomes a real issue as well with
Exactly.
SIDS.
Okay, so how would you, as a parent, know that they need to come in and see you if their baby has maybe a symptom of the flattened head? I mean, how would you recognize that? I mean, is it really noticeable?
So that's a good question.
In all cases, or?
That's a good question. In most cases, it's noticeable. And again, it's important if you do notice it to talk to your pediatrician. Most of our referrals come from pediatricians in this region that have recognized that sometimes it can be treated with a helmet, and sometimes if you have suture fusion, it becomes something that requires surgical intervention. But again, they sort of depend on us to make that diagnosis and to provide treatment recommendations. I think if you're looking at your child's head and it doesn't look right to you, then it really warrants a good assessment. One of the things that we're always looking at and assessing, and in addition to looking for the sutures and any ridging of the skull, any misshapen position of the head, we also look at the fontanelles and the soft spots, and to make sure the soft spot's not closed too early or too late. So these are things that we all assess with these children. So I would say that if you're a mom or a dad or a grandparent and you're looking at your child's head and it just doesn't look just right to you, then go see the pediatrician. And oftentimes the pediatrician will end up referring, like I said, we have 3 clinics a month that are totally dedicated to this. And I think the Snell's people come around at least twice a week and make adjustments on these helmets. Because once you get a helmet made, that's not the end of the story. They every 2 weeks have to do some adjustment.
Oh, okay.
Either adding some material or removing some material more commonly to promote the proper growth of the head into that position.
Yeah, that makes sense. Hey, Karen, good afternoon to you. What is your question?
Well, my question is that when I was a baby, I fell to the ground from a stroller, and it was one of those very tall strollers, if you can imagine, like a pram-like stroller. They look more like cribs than strollers. And I have a indent in the back of my head, and I have it on the other side, but not as bad. But it definitely feels like when they hit a car and it's got an indent on the side of it, that's what it feels like. And I don't know if that affects a person's brain or if it affects their, I'm not sure.
Okay. So she fell when she was a baby from a stroller that was really the height of a crib, and she's concerned it may have maybe affected her brain.
Okay. How old is she now?
And she has a dent in her head. How old are you now, Karen?
63.
63 years old.
Right. And
But I noticed it
normally?
earlier
I would
on.
understand. Are you functioning normally, Karen?
Yes, but I get very weird headaches every once in a while. I also have gotten what they call a neurological, what do they call that? Those headaches that can last for days.
Migraines?
Oh, migraines, yes.
Yeah, she gets headaches that
I
can
get what
last
they
for
call-
days.
But
Well,
it's not a headache.
That's
It's
certainly
me.
possible. I think, given this time span, I wouldn't expect there to be any kind of mass effect in the brain. So I think it's more or less, you could have had a concussion and had some long-term post-concussive effects from that. I would recommend that you go see your family doctor. Who more than likely, and you may be seeing one now anyway, who manages your migraines. And my recommendation would probably be to ultimately see a neurologist, because they're really they're the experts on managing certain brain conditions, in particular things like migraines or cluster headaches and things like that.
Does that help, Karen?
Yes, it does. Thank you so much.
Okay, thank you for calling.
Thank you.
Okay. Yes, so we looked at the photos and the helmet. Do you see a lot of patients with the conditions of having to use a helmet, the babies?
We probably see about 100 a month.
Really?
Right.
Throughout the Arklatex?
Throughout the Arklatex. And we're fortunate because there are some different sites within the state to get adjustments, but I'd say we would probably do more than just about any other facility in the state of Louisiana related to this. And we're very fortunate. I can remember when I first began treating kiddos with this condition here in Shreveport, I'd say back in the mid-90s, there was no one in this region that really dealt with these helmets, and the one or two that did, the helmet really wasn't very good. These are excellent helmets that are really custom made to the children. Like I said, we don't have to take a big, huge plaster molding of their skull like we used to. It's basically a 5-minute non-invasive little laser scan. And the helmet is made within 2 or 3 weeks. And it's a fantastic thing to think that right here within the Arklatex that we have this technology. And back in the 90s, even to early 2000s, I was having to send folks, Jade, to Dallas to get adjustments every 2 weeks.
Yeah, that's amazing. What is it made of exactly?
It's sort of a polymer, a plastic on the outside. It's as you can hear, it's fairly hard, and then on the inside, it's almost like really, really thick styrofoam.
Mm-hmm. Yeah.
And it's very durable. It's very, like I said, you just basically put it on their head and kind of strap it on like that, and then they go for it.
Yeah.
And it helps with their ear position, it helps with their forehead position, it helps with the back of their skull. And again, not every kiddo that has a little bit of head misshapen requires this. We try conservative measures,
right.
Tummy time and physical therapy and things like that. And if it's a very small thing and it's a girl and they have long hair and it's in the back, maybe you can cover it up.
Uh-huh.
But if you're a boy or you're a girl that wears their hair short, it'll show.
Yeah.
So.
Well, wow, that's so interesting. I just would have never known about this had you not been on today. So It's a really interesting topic. So thank you so much for sharing this with us, and getting the word out about SIDS is so important because
Sleep
like we
on your
mentioned in the
back.
beginning, we want to save lives. But we got to wrap up now, and thank you, Dr. Ghali, for coming in today again. And yeah, we got to go. See you guys later.